What a great pleasure to be here. Thanks for the invitation. Okay, so I am going to talk about, this is really switching gears. I hope you are interested in this topic. It's certainly something that's very topical throughout the world at the moment. I'll touch on rehabilitation robotics, but the focus of the talk will be on non-invasive brain stimulation, its relationship to neurological recovery. So this is where I spend most of my time. It's the rehabilitation hospital just north of Manhattan by about 30 minutes. We run many different studies, pretty much focusing on motor recovery. Actually, that's my expertise as a clinical neurophysiologist. And we have a number of different diseases that we deal with, both acute neurological damage and degenerative diseases as well. And we do thousands of treatments each year. I direct a program there. We have a number of inpatient and outpatient laboratories. The majority of the work is funded by highly competitive National Institutes of Health funding. So we've been fortunate to be part of that. We have several grants at the moment. Just a little bit on the approach. So I'm not happy with the status quo. I think we can do better with treatments. I think that the treatments available for the patients I deal with motor dysfunction are partial, and they certainly leave people still with a lot of disability in the community. So I've been trying to understand how we can leverage pharmacology, behavioral intervention, brain stimulation. More recently, people are doing stem cell injections, but I'm not going to discuss that today. I think each of these components has benefit and limitation. None of them are a panacea. I'm particularly interested in the combination of therapy. So pharmacology is great. It has specific targets, but it also has side effects and broadly affects the CNS. Brain stimulation is emerging as a tool that can definitely influence brain function, but the effects are fairly short-lived. Potentially we can use brain stimulation to make areas of the brain more susceptible to pharmacology, and that's something we're investigating at the moment. But I quite like behavioral intervention. I have a lot of background in this area, so we know that getting patients to engage in meaningful, goal-directed, voluntary activities on a regular basis with suitable feedback, they can make gains. And certainly from a neuroscience perspective, it's because they're engaging their functional networks like we do when we're learning the piano or math. So I'm particularly interested in combining behavioral interventions with brain stimulation. I'm always conscious that the plasticity that neuroscientists talk about can be adaptive and maladaptive. So not always can we get a positive response. So examples of this is the cramping that musicians can get, called dystonia, or in patients with chronic pain, for example, where the stimulus has ceased but the brain still perceives pain. So I'm always conscious that we can actually generate maladaptive plasticity. We need to avoid that and work towards adaptive plasticity, such as functional improvement. How I do that in the motor systems, but you probably, many of you interested in other higher cognitive function, although there's parallels, is to understand the patient, the intervention that's given, and the combination of the patient intervention. And I spent a lot of time going through some detail in order to do that effectively. I'll start by talking about robotics. Here we've had a long-standing relationship with MIT in Boston, which are the pioneers of rehabilitation robots. They're primarily used to partially restore motor function, and that you can exercise the hand, the wrist, the arm, the foot. And there's good evidence that you can get a clinically meaningful improvement. This is published in the New England Journal of Medicine recently. And so we do thousands of sessions of this robotics. It also can quantify movement very well. So here you have on the left a graph of somebody with dysfunctional movement, and after some time of training, these point-to-point movements through thousands and thousands of repetition with lots of real-time and progressive feedback, they can re-establish better motor control, and that translates into better function. I like this form of therapy because it's very well quantified, and for the allied health professionals, you'll know that therapy is quite a nebulous topic, and dealing with scientists and clinicians and funders, you need to really understand how how much therapy you can expect in what patients, for that, you really need to have very well-defined therapies. And so I use these robotic tools to quantify the performance of the individual and to use as a therapy upon which to start testing drugs and brain stimulation. I thought it's useful to show you what brain stimulation is. There's a lot of talk about this in the popular media and the scientific media. We've had CNN and CBS and other people do recent stories on this. So it's always nice to show you what it looks like. Let's see if this video works. So here we have a 3D reconstruction of the subject's MRI. You can see the coil held adjacent to the scalp, and you can see him holding up the hand. If you watch the finger and the thumb, you'll see a little twitch that's associated with a single pulse of this electromagnetism. So this technique has been around for about 25 years or so, 30 years. I've been working with it for about 20 years, and it's very well studied actually. It's painless and requires some expertise to actually do it, but it's very easy for the subject. It results in a single sudden activation of many cortical neurons that secondarily buzz around in the cortex and activate these projection neurons that come down to the spinal cord and out to the hand. And there's many different ways we can use this to probe brain excitability in ways that we can test drugs and we can test function. And especially when we combine it with other techniques such as functional imaging or EEG. As part of NIH-funded studies, I have to do many different outcome measures, so I'm always grappling with assessing the person's function and assessing the person's biology and what's meaningful. And this transcranial magnetic stimulation kind of fits in with the other tools we can use, the MRI, the clinical scales, the quality of life scales, etc. And also we're grappling with the sensitivity, reliability, and functional relevance of what we choose. So how does this non-invasive brain stimulation affect motor cortex? Well, I have a little a schematic here, and this really just shows here the TMS pulse, the little lightning bolts up on the left, and non-invasively. No current actually passes through the skin and the scalp. It's transparent to this magnetic field. But with sufficient intensity, you get electromagnetic induction, so you get electric currents inside the cortex. And you get this wave of activity. That blue triangle is a corticospinal cell coming out of the brain, and the little squiggles are recordings from the spinal cord, showing that you get these wave of activity at different latency that goes down to the spinal cord. And the graph on the right shows that if you do pairs of pulses at different intervals, you can nicely probe their brain physiology in the awake human painlessly. And there's a lot of literature on this, and I've been using this technique for some time, and I teach people how to do this technique, scientists and clinicians. And it was also to remind me that a colleague in Montreal actually showed that relative to the discussion this morning on concussion, that 30 years after a concussion, you can use this technique to show changes in brain inhibition that reside without clinical symptoms. So it's a tool that we can understand if there is residual pathophysiology. This is transcranial direct current stimulation, which is two electrode pads, this has been done for about 10 years or so now. This is a lot simpler. The other device is worth around $100,000 to $300,000 and requires, a training course at Harvard, etc. This one is in the order of $1,000 to buy. People are making their own for less. And simply is a rubber electrodes inserted into a sponge which is saline soaked and put onto the scalp. And so you would think, does any of that, and then a weak electrical current this time is passed between the two electrodes, direct current. Around 2000, a colleague in Germany showed that actually you could modify brain output by doing this for about 20 minutes. And the size of that muscle twitch that you saw increases after doing this for 20 minutes, although that's transient as well. So this doesn't overtly lead to activation of neurons, it just increases their probability of firing, and people have thought that that has potential clinical merit. and has started really an explosion of interest. This shows you an approximate timeline. There's so much interest in this at the moment that the Institute of Medicine in Washington, D.C. invited me to give a lecture last year. So I just did a quick search of PubMed and had a look at how many papers there are and when they started. And you can see an escalating increase in the number of publications for both the direct current stimulation, those saline-soaked pads, and the repetitive transcranial magnetic stimulation. The magnetic stimulation preceded this direct current stimulation. What I didn't say about that, the video where you saw the muscle twitch, was that only lasts for about several hundred milliseconds, so a lot less than a second. But if you do it repetitively, over time, and then you stop stimulating, the brain is in a different state at that time, and you have these transient effects that last around an hour to an hour and a half. In the motor systems, it can upregulate output so that the person can start to activate their hand a little bit better. This, in fact, is FDA approved for the treatment of medication refractory depression in the United States, and there's a lot of work going on in this area right here in Canada as well. So both of the things I have here are neuromodulatory techniques. They are intended to alter brain function for functional improvement. There's so much interest here. There's around 10,000 publications on PubMed for the RTMS and around 2,000 for the TDCS, the electrical stimulation. And there's so much interest in it, in fact, that the journal Nature invited myself and some colleagues to comment on the potential utility of this because it's really going a little out of control, especially for the direct current stimulation, because it was never marketed as a medical device. So people are building their own and selling, like people are using these devices for improving their Xbox function. Parents are getting their kids to use these devices because some publications from a colleague out of Oxford showed that it can improve math learning. The military are heavily using this, and I won't talk about that as well. So there's a lot of interest, and so we thought we should put the brakes on and make it quite clear that these things can modulate brain function, and not all of it can be potentially good, and we need to do it in a way that's controlled. And people like myself are spending a lot of time and a lot of taxpayers' money to try and understand how this works and why and in who. And so we thought we'd better just put the brakes on by publishing this and showing people that really it needs to be taken seriously. I'll mention a few things about stroke. I study largely stroke, and this is where the majority of my funding has come from. Because although I've studied spinal cord injury and we have grants for that, traumatic brain injury, but this highlights something that's educational, I think, for this group as to the rationale for doing brain stimulation in neurological disorder. And so in stroke, you have this is a cross-section of the brain, just a cartoon showing that you have an isolated lesion of the brain that the day before was functioning perfectly well, and that sets up not only the output of the brain from that area that's reduced, but this disruption to a functional network that's pathophysiologic and persists for some time after. And in particular, a network that goes between both hemispheres of the brain. And this concept is much more broad than studying the motor systems. This is also for neuropsychiatric dysfunction, for non-motor systems such as the visual system. So it's a nice model, but it represents current thinking by non-motor physiologists and psychiatrists, etc. So the idea is if the output of the brain is affected, the excitability, maybe we can modulate that with brain stimulation. And so a lot of groups tried to do that, either using the TMS coil or the electrical current, the TDCS it's called, and they either tried to increase the output from the area where the brain lesion was, or reduce the output from the other hemisphere that for some time it's been known that this is also pathophysiologic, even though the network, that there's no overt tissue damage there, it's part of an important functional network. And so this was great, and there's a number of publications that have supported this, and it's not an exhaustive list. They can modulate brain function. It does translate to improvement in behavior, but the problem is it's still not really powerful. It's not a drastic improvement, and it's short-lived. So it's only lasting an hour or so. If you increase the dose, do it over several days, you can get a better, a more lasting effect. But I thought probably the best thing to do was actually to combine it with repetitive behaviors, such as cognitive therapies, or in my case, motor therapies. And we know from the animal studies, I will show you a little bit of science for a couple of slides. We know that this is a rodent study, but this is what happens in your brain when you're practicing the piano or you're practicing a golf swing. This is after 1 hour. You can see the little images down the bottom, and there's these things called dendrites that stick out from neurons. And they start to form after an hour of practice. And this paper, there's other support for this, but this was a nice paper for me that highlighted that we have structural changes in the brain resulting from less than an hour of practice of repetitively doing something. And this is a fundamental underpinning of learning and memory, and it's important for all of our human function, and it's important for patients' recovery as well. So we know that these structural changes occur. This is showing in non-human primates as well as humans that the motor map, the representation, the physiology changes over time.
Is that 1 hour consecutive?
Yeah, well, in this particular case, I'm sure they work these rodents very hard. I don't do this kind of work, but they literally have to try and get the food pellet, so they're doing it, they're highly motivated, and they're doing many, many repetitions. But the theory is the same for us practicing something for an hour. So, and we know that the physiology changes because we can map out cortical representation changes that relate to skill, or sometimes don't relate to skill, even simple movements. So we know in humans that the same kind of phenomena occur even in short term and in long term as well. So the thought was maybe we can combine these interventions, and certainly a lot of people are doing that. It's approved for this kind of stimulation for depression, as I said, and now many psychiatrists are trying to combine with cognitive behavioral therapy. But I'm I like to be critical and a pessimist and only accept things when they're proven. And I found some evidence in the literature that if you try and combine things, they might not always work out positively. And there's a lot of information on here for those who are interested, but for everybody else, on the vertical axis, it's just showing the output of the brain response, where higher is better, and the interaction of two different kinds of treatment. One is the direct current, and the other is repetitive synaptic activity from transcranial magnetic stimulation. And in a nutshell, these black triangles should elevate after one of these interventions and then be sustained for some time afterwards. This is what the literature says, and it's been reproduced. If you combine these two interventions, you not only have a reduction in the effect, the after effect, but you have a reversal of the effect. So I didn't always assume that combining behavioral therapy with brain stimulation would be positive, and this was the kind of data, and there's about 40 or so papers that support this concept. And I can't overstate the importance of this, because I get many clinicians who are trying these kinds of things off-label that you probably don't hear about, because there is approval for one indication for depression. It means that they can use, in the case of TMS, they can use this device for other things if they think it's beneficial with their clinical judgment legally. And so they're doing it in many different ways, trying to work out the best way to actually apply it. And I'm showing data like this that shows that if you do it the wrong way, you can have a reversed effect, so be careful. And the things they're asking is, can I combine these two therapies? If I give double the dose, do I get double the effect? If I give a longer period of treatment, will it be beneficial? And I'm saying systematically test it. I was thinking for my area, if I know that this behavior for, in this case, motor training gives a good improvement and the brain stimulation gives a good improvement, I don't know what to expect until I formally test it. So I did formally test it, and these little squiggles here are before brain stimulation. This is the size of the muscle twitch that you saw when that person's hand twitched. I gave some electrical brain stimulation here, And this is in actual patients with brain lesion and some hemiparesis. It increased their response to the brain stimulation subsequently, and then they performed some behavioral therapy, in this case an hour of robotic training, and they still had an enhanced output after that training, and it gave me some credence to the idea that we could combine these things safely and effectively. Here are the group data, and just to show you that the rest of the group showed the same thing. And importantly, at the bottom here, a cortical inhibition measure, which is known to be important because if you reduce this, the brain learns better, and there's good support for that. A reduction in cortical inhibition promotes the long-term synapse formation, and this was highly associated in the study that I did. So that was great because the physiology looked very promising, but what about behavior? How did the behavior change? So we assayed their behavior as well, and we found that this concept of movement smoothness in the motor systems, that's a very advanced ability that takes a lot of rehabilitation to get back movement smoothness. We could find an improvement with the right combination with a single session of this combined therapy. And that led to several $1 million for a clinical study that I'm running from the NIH. And this is the basic study design. I think you have it there on your notes, so if you're interested, you can ask me about it later. But the concept is that we do a series of weeks of this. In this case, it's 12 weeks, and we use the clinical outcome, an accepted gold standard clinical outcome, as the primary endpoint, and we check whether it's there 6 months later when they finish this combination too. So we've done a few thousand treatment sessions. We're halfway through the trial. I'm blinded to the trial as an investigator. It's a very well-constructed trial. This is basically how the clinic looks. And but we're also running another trial not using the electrical brain stimulation, but using the magnetic brain stimulation. You can see a picture of how that looks in the bottom right. And this is a multi-site trial across the US going right now. We're one of the leading sites with recruitment. And here they get inhibitory stimulation of the unaffected hemisphere. This is in chronic stroke patients also with an isolated lesion. The other side of the brain that's not affected, we're trying to down-regulate the output because imaging studies and physiology studies show that that side of the brain is actually pathophysiological and it impedes the progress and return of function. So this study is their pilot data from Rehab Institute of Chicago has shown that using navigated brain stimulation, delivering this inhibitory protocol like in a dental chair, exactly like this, prior to them going to their occupational therapy, in this case, not robotics, they can get a more profound change in clinical function than doing the therapy alone or the brain stimulation alone. So these things are promising, and this is registered with the FDA. I mean, these are very expensive trials done over several years. So there's a lot of interest here, but the truth is, it seems quite safe to do. These techniques, you can induce a seizure, and it has, and that's not happened under my care, but it certainly can. You're interfering with brain function. But there's really quite well-established guidelines from the International Federation of Clinical Neurophysiology. If you practice within those guidelines, it's very, very safe. In fact, with the seizure being the most prominent risk, but with the right stimulation parameters, it's now being used as a treatment for epilepsy. And in further, in some cases, it's being used to cause a seizure and potentially replace electroconvulsive therapy, which also causes seizures and is done routinely. But what's the state of the science? So I think that this is a lot of promise, but I think that it seems to have a good safety profile. There's many clinicians and scientists around the world doing this now. There's great work right here in Toronto being done, in Montreal and in Vancouver and elsewhere in Canada. But what's the state of the science? Well, in a nutshell, we do see good effects. They still seem to be relatively transient. They do relate to function across a range of different acute and degenerative neurological disorders. But they're is inter-individual variability. So I'm trying to get to the bottom of why patient X doesn't seem to respond well and patient Y responds profoundly. And certainly we're seeing some very large effect sizes, but also in some people nothing much happens. So we're trying to understand that better, and one of the ways we're doing that is by having more focal stimulation and also timing the listening to the brain at the time of the stimulation. They're the two probably take-home points of where this field is going, and in the last couple of slides I'll just show you what that means. So we do high-resolution MRI scans. We have a group in Manhattan of biomedical engineers that do the 3D reconstruction, and we test different montages for electrode stimulation to try and get more focal stimulation, and we've proven that we can do that. They segment out the skin and the bone and the CSF and the grey matter of the brain and the white matter of the brain because they all have different resistance properties. And then experimentally, which, this is how experiments look with wires everywhere and machines that go bing and recordings from muscles, etc. We focused in on some of the electrodes using the electroencephalography positions, and we have what's called now is a high definition electrode we have in the center, which is where the current is driven in, and we have return electrodes which are surrounding where the current is returned. And I wanted to prove to myself that current actually gets in the brain, because I still had colleagues in London saying, does current actually go into the brain? I mean, show me some hard evidence. So we did some experiments and we proved that we can get current into the brain and that these models were robust. On the right, you see these little squiggles, which are the muscle response. And the models predicted that we needed a different voltage to drive the current in based on the structural anatomy. So the modeling data was exactly in line with the physiology that we saw. And similarly, so it predicted that if we gave everybody 600 volts, which sounds a lot, and it is a lot of current that they get, but it's for a very transient period, that we will not elicit a response in this person, but we will in the other two. And lo and behold, that's what we showed. We showed that there was some focal specificity as we moved this around to different parts of the brain. We also compared electrical stimulation with magnetic stimulation and found that at this spatial resolution they were comparable, because we're trying to understand which of these should we use. The transcranial magnetic stimulation is very expensive and it requires a lot of training. The transcranial direct current or electrical stimulation is very cheap, and kids are doing it at home and seems to be more accessible. Maybe we had better understand that. So we're very interested in comparisons between these two techniques, and there hasn't been a head-to-head comparison about which one is more effective. They both seem to be able to modulate cortical function. So on the last slide, I'll just explain that we're also using EEG, which is electroencephalography. It's not exactly my area of expertise, but I'm working with some of the world's leaders who are using my expertise and I'm using theirs to try and understand, to listen to the brain while we're stimulating the brain, acknowledging that everyone has different anatomy and they're getting slightly different dose of stimulation, and listening to how the brain responds. And we're coming up with ways of safely monitoring the brain and terminating the treatment when we hit a desired physiological response. And so we've published this, and we're embarking on further studies with this, and that's very exciting. And this kind of technology, this cap that you can see here, is the technology is getting cheaper and getting very, very advanced. So in this cap, it has electrodes that can record brain activity from various sites. It has electrodes that can stimulate the brain with direct current or with alternating current or different frequencies. In the pouch on the back, it has a cell phone-like device that transmits all of this information wirelessly, so people can walk around with this thing on, and has an accelerometer and gyroscope and all of those things inside it. In fact, I just noticed a paper this week by another group using this device, and they claim telepathy because they listen to the brain of one subject wearing this cap, and they transmit it wirelessly to the other person who's nearby, and then inject that pattern of brain activity into the other person so that that person knows the brain activity of the other person. And by doing that, they claim that they've been able to transmit words like hello and goodbye. So where is this going? Well, I guess this was a broad topic that I've covered. We're trying to, it's happening everywhere. There's a lot of trials underway. There's 500 clinical trials registered for TMS and around 100 or so registered for the electrical stimulation. This is registered on clinicaltrials.gov. So there's a lot of people taking this very seriously. There's some, probably some rogue clinicians that are really trying some out there therapies, not illegally, but as they're learning what is a good treatment dose, and then what happens after the treatment. Do you stop treatment, or do you have some kind of maintenance schedule? Can you combine therapies? And then there's all of the public and the investors and the medico-legal aspect of it as well, which is really catching up. This is one of the fields that, unlike other fields in medicine that start with the animal studies and then go through these stages of clinical efficacy trial, this kind of started with going straight to the human. In 1985, when the TMS was first demonstrated in England, it was immediately adopted in laboratories with ethics-approved studies. So it's a field where the human work has preceded all of the basic sciences work, but that's slowly catching up now. So I have, well, a lot of people that I work with around the world and in the US, and I'm grateful for the funding from the NIH and foundations. So thank you very much for your time.